back, everyone. This is episode 4 of the Fresh Air series, and we're going to go through some great cases with Rennie again and have our great panel that you all know. And take it away, Rennie.
Hi, I have 4 more cryobiopsies for today. It's again ILD, so stuff for grown-ups. And here I'm going to read the short story, and you decide who is going to talk about the case. So here is case number 5. It's a 60 years old woman who is a smoker and has positive Raynaud and positive ANA. Is that the way you say it, the antibodies?
Yeah, positive Raynaud's and positive ANA. Yeah.
ANA. Okay. So his father died of IPF, and the CT says DIP.
Ooh.
Who wants this case?
I can take this first one.
Okay. Sorry. Are you seeing yourself big? Okay. Do you see your pictures? No. Okay.
Yeah. So these are cryobiopsies, and then you have some liver that's orientating it in the top right. Is that? Yeah, perfect.
So let's begin with the first fragment. That is this one.
Wow. So really quite prominent lymphoid aggregates that we're seeing. And then there's some also inflammation within the interstitium. I'm not really seeing, there are some pigmented macrophages there, but that to me is just in the spectrum of a smoker. They're not diffusely filling the space. So that's not really what you would expect to see if in the term of DIP. It's just a big airway. Another fragment of alveolar lung here. So a bit of inflammation in the interstitium. It's on the minor side. A bit of collapse here. There's a little bit of fibrosis, but
I think this fragment is artifacted. You see, okay. I see a lot of recent hemorrhages, and I think these macrophages here are not hemosiderin laden, but are these
smoking
pigmented alveolar macrophages. So I think these sometimes fragments in cryobiopsies are artifacted. So I think it's what happened here that has artifactual hemorrhage. But okay. This case because it has many macrophages.
This one's fairly normal, I would say.
Maybe a little emphysema?
Yeah, a little emphysema there.
And again, macrophages?
Yeah, so I think in this case, I would be largely descriptive. I don't think I could definitively call this anything. I think I would describe the findings that there's some pigmented alveolar macrophages, a little bit of inflammation. I'm not seeing a definitive fibrotic lung disease here. There's very minimal fibrosis, but it doesn't really look like that ropey collagenous fibrosis that I've seen so far in these pieces. And then there's some lymphoid aggregates there, which I think are also a non-specific finding. So I think I would be descriptive in this case and maybe comment on a bit of emphysema as well, but I don't know if we have a definite explanation for what's going on, unless others can put it all together.
Anybody else wants to say something, or would do it somewhere?
No, I agree with Matt. I would also be descriptive. I think there's smoking-related changes in the background, and there's some lymphoid aggregates, some inflammation. It's all very non-specific, all of it.
Yeah, and also wanted to add germinal center formation. Is that real germinal center in those 2 lymphoid aggregates, little pale areas in the center? Again, I think the thought process here is patient can be smoking and also have connective tissue disease. So there could be 2 things going on, or they could be weird. So when two things are going on, we don't have to struggle trying to combine everything into one. And I agree with others that descriptively describing this would be helpful for the patient.
Great point, Raghav, about two things can be going on. Great point. Yeah.
So before I say, I would like to see if the bronchovascular bundles are carrying a bronchiole also along with the pulmonary artery.
Yeah. do have more levels of this. So here I have a big bronchi, but I don't think if I'm going to be able to answer your.
Because minimal
Yes.
change, so constrictive bronchiolitis, a small airway disease is going on in my mind, especially in this fragment.
Well, I haven't seen it. I haven't seen it. Here I see the muscle attached to the epithelia. That's what I would call constrictive bronchiolitis. That the bronchiole disappears, or it has a thick fibrosis under it.
Can I
But
make
the
a
best
comment?
way to.
Irene,
Sorry?
can I make one comment? Sorry to interrupt you. So one thing about Sharda's point, because they say that a lot in textbooks, that you must, look for a partner and airway narrowing, constrictive bronchiolitis. I've noticed just anecdotally, no evidence, but I've noticed in my practice, because we see a lot of transplant, we see a lot of true obliterative bronchiolitis in transplant rejection. I feel that outside of the transplant setting, true constrictive bronchiolitis is almost extraordinarily rare. It's very, very easy to overdiagnose constrictive bronchiolitis because of a little narrowing, a little, you can't see the bronchiolar partner. It's very, very easy to overdiagnose constrictive bronchiolitis in a non-transplant setting. So I'm very cautious of that, not to overdiagnose it.
Okay, got it.
So, well, in this case, I was descriptive, as you mentioned. I said emphysema with pigmented alveolar macrophages and one fragment with inflammation and lymphoid follicle. You can imagine that when this comes to the MDT, people wonder about these follicles because the patient had. This is what happens, but we cannot answer. This is not an SIP, and I found this biopsy was interesting because I see lymphoid follicles in many biopsies, and especially in smokers. When you see the explants, they have many lymphoid follicles, and I found some papers that talk about lymphoid follicles in smokers. That it's inflammation, and it works in many entities, not only in those that are connective hepatitis, but when you see it, you have to report it, and it makes the discussion go, and nobody's going to think this is not connectivopathy again. But what I see is smoking related everywhere. Here, despite it's slight and smoking related, it's not SRIF. I mean, it's only pigmented macrophages, but this descamative pneumonia they are seeing probably is smoking related and not because of an NSIP or something. So not an SIP, no UIP, descriptive smoker related. Agreed,
Irene. Actually, your lymphoid follicle observation in smokers, I have also seen exactly the same thing. And I tried a little bit to document that in our AJCP paper, to document that those cases also have a lymphoid follicles here and there. Actually, this would be another great study we could do if we have, just collect a couple of cases of smoking related whatever from all our institutions and just see how many lymphoid follicles are in each. Very easy to do, and it would be a good message to put out there in the literature that you can get lymphoid follicles in things that are other than connective tissue disease. I think the pushback will be, they'll say, well, did you test for CTD in those cases? How do you know that they don't have CTD? That argument just goes on forever. The CTD maniacs, will never admit that something is not a CTD, even if the CTD workup is negative. Because the final argument they always have is, well, CTD is negative now. How do you know there will not be a CTD 15 years down the line? So there's no way to prove that kind of thing wrong, So they will never accept that the lymphoid follicle is not specific for CTD.
just like hypersensitivity pneumonitis. Doesn't matter what you have in the biopsy because they can still suspecting. It's not in our hand. You have to describe what you have in the biopsy and if it fits okay and if not. Okay.
Yep.
Yeah. Anna can come back anytime. ANA.
ANA. So let's move to the next case.
Great.
So case number 6 is 70-year-old male who is an ex-smoker and has morning cough, and he had pulmonary fibrosis diagnosed 10 years ago in a ward revision. I imagine that just by CT. The CT says UIP. When the CT says UIP, I don't know why we get a biopsy, but I got it. I got it. Again, this is a cryobiopsy here with this piece of kidney to localize. I have this. Well, who wants to talk about this biopsy?
I can talk about it since I saw the kidney.
The kidney is okay.
Yes. Yeah, the kidney makes me think that it's all real. So yeah, we do have pieces of lung here with a big blood vessel right in the center going across. And then we have different irregular spaces, alveolar spaces. But I don't see any free-floating septa or anything to think of. Maybe there's some free-floating septa to think of some emphysema. And then some of the interstitium is, I think, little bit thick, not in all the areas. It's only patchy. It's only very focal kind of areas. Yeah, right there. Yeah, it's little thick. And then there is also in that area, I saw some prominent reactive pneumocytes, like plumpy looking cells lining that. But otherwise, yeah. Let me annotation. Trying to find the annotation. It's right here somewhere.
The fourth by the right in mind.
Yes. I think these cells right here and these guys right here, plumpy looking cells. But I'm also looking for some macrophages. I found some macrophages because the theme of today looks like macrophages. They do have some pigment within them. So I will just call few sparsely distributed pigmented airspace macrophages with some interstitial thickening. There's also smooth muscle hyperplasia in some of those expanded interstitial areas.
What about
Other
this?
than this area, yeah, I was wondering if it doesn't have a perfect picture of a fibroblast foci, but it does have
Not
some
perfect.
pale.
Or here.
Oh, yes, this one looks like a fibroblast foci here. Yes.
I'm going to look for more about you because it's where I wanted to drive you.
Yeah, they also look like some interstitial expansion with pale fibroblastic tissue. So those could be fibroblast foci, but I don't see any mature fibrosis in that piece. But coming to this piece, there's a lot of fibrosis for sure. And there's some interstitial inflammation, lymphoid aggregates. So there's fibrosis, there's fibroblast foci at the junction. Back, you have mature fibrosis, and in the foreground, you have some uninvolved, but the piece ends right there. So it's difficult to say if it is really at the interface, but I want to give it a chance, consideration of an interface kind of fibroblast foci. This one looks like a airway, wall of the airway, smooth muscle of the airway. And then there's some surrounding alveolated parenchyma where there's little expansion of the interstitium. So yeah, so this patchy fibrosis the fibroblast foci, there's some macrophages, no honeycomb changes, with the history and the radiology UIP. I don't have the spatial orientation, if it is subpleural or paraseptal, that kind of a thing. But again, I would be descriptive in this, saying that there's patchy fibrosis, there's some fibroblast foci. This could still represent UIP in the proper appropriate clinical setting. But in the cryobiopsy, I'll be descriptive and take it to the MDD and then fight between smoking related and then UIP, and also look at the radiology, how the radiology globally has involved. If it's a lower lobe predominant process, and where did they biopsy this from, which part of the lobe or where exactly. So those details I would collect, and then looks like it's an MDD final kind of a thing.
As you say always that my biopsies are so good, I wanted to bring my normal biopsies are like this. This kind of, I have to deal with this thing. That is not bad because I have a piece that is big, but this is, I think, what most people that are looking at cryobiopsies are facing. Some fibrosis with some fibroblastic foci, and what are we going to do with this? Because there are also smoking, as Raghav said, smoking related changes, maybe. So what do you think, the rest of you?
Yeah, this is a very good example of, actually what Raghav said is a very good example of what, how many people approach it, is bring it to the MDD and all that. Like for me, this is UIP. This is just UIP on the biopsy alone, and it doesn't matter what the MDD says or what the radiology says. So I do not see the MDD's role as telling me what the biopsy finding of your UIP is or isn't. I see the MDD's role as what to do with the biopsy finding. Is it to place it in a clinical context, to whether they want to call it IPF or not? I don't see the MDD as saying whether a UIP case is UIP or not. I will accept this is like, it's not as great as a surgical lung biopsy, and Raghav's point is well taken about you don't see the distribution and all that, but you have architectural distortion, you have fibroblast foci, you have one piece which is completely scarred, you have patchwork pattern. The only thing you're missing is honeycombing, but other than that, you have UIP. I mean, I don't see why I would step back, but what Raghav said is exactly what many people do in this setting, is they will wait for the MDD and then kind of take it from there. I think that's the reality of this of ILD practice. But for me, this is UIP. That's what I would call. Any the other, Sharda, Matt, what do you think?
I have to say, I don't see a lot of cryobiopsies in my practice, so I agree. It's suspicious for UIP, but I don't have a great perspective on how far to go in this cryobiopsy, because I'm used to seeing wedges for them.
I agree with you.
Matt is thinking, poor woman, she has to deal with this piece of tissue. This is exactly what
Yeah,
happened.
we get similar kind of cryobiopsies here, much smaller. But like Sanjay was saying, like this finding, definitely the UIP would be the leading differential diagnosis. And you can definitely argue there's nothing else can look like this. And most of the times we have the radiology available, the findings available, more than just the just what they say, the description. We do have access to the description. So generally in the comment, I tend to say that this could still represent UIP, and also the only thing the MDD can help in this setting can be to exclude other causes which can give rise to an UIP kind of process. That's the only other side I can see, but I agree with all the comments and also Sanjay's perspective on this, that the features are there for UIP.
So Raghav, one way to look at it is to look at it from the liver, kind of like the liver pathology point of view. Yeah. So in liver pathology, when they get a cirrhosis case, the cirrhosis people, the liver pathologists, they say this is cirrhosis,
Yeah.
right? They don't say, let's wait and take it to the MDD and see whether he's drinking alcohol or not,
Right.
right? Because what if they say it's Wilson's disease, then this won't be cirrhosis, but in lung, we don't look at it like that. We say, well,
Correct.
what if they say he has a parakeet, then it will turn out to be hypersensitivity, then I will look stupid because I said UIP and it's actually not UIP. So,
Yeah.
the problem is in our system, not in the, our system is we don't have a cirrhosis equivalent diagnosis in lung pathology. Actually, there is a diagnosis, and that's UIP. There is a cirrhosis equivalent, but our way of looking at it is very different in lung than how the liver people look at it. I think their system is much more practical, is that once they see the cirrhosis pattern, they just call it cirrhosis. But when we see the UIP pattern, we're like, I don't know, So I think there's a difference, and I think we would be much better off if we had a liver type system where we could call it what it is, and then they can do whatever in terms of etiology. It
Yeah.
would be much
Agreed.
better.
Maybe the
Agreed.
criteria are not that as good as in cirrhosis, because if we say patchy fibrosis with fibroblast foci is UIP, but you can have patchy fibrosis with fibroblast foci in a pneumothorax, because I've seen fibroblast foci in a pneumothorax. Then they give you a piece of pneumothorax without history, without CT, and you are done, because you say UIP. And then they would say, but this pathologist is stupid. No.
Yes. Good point, Irene.
Sorry, Sharada, you wanted to comment something?
Even I signed it out because of all the features that Sanjay had mentioned, like, patchy fibrosis and fibroblastic foci. And yeah, I couldn't see any honeycombing, but still I would like to put it as UIP.
These cases that are like this, or don't have everything that UIP says, I diagnose it as patchy fibrosis with fibroelastic foci, and I make a comment saying that this has some elements of UIP, but not all, and this is a probable UIP or something like that, and I leave it like that. I think the ground truth is not the CT. That is the problem that Sanjay was saying, that we say, oh, let's go to the MDD to know if I'm right. No, the ground truth is what happens to the patient, and if this patient it's under transplant in 3 years, this is UIP. This is the thing. But this patient died, and we will never know. Sorry, we would never know if this is UIP or not.
So what about this terminology, unclassifiable interstitial fibrosis?
Sorry?
Yeah, we do use it, Shardas, actually fairly commonly for cases that are fibrotic ILDs, but don't have classic UIP, that we cannot call UIP on pathology. We end up saying, well, I cannot classify it any further. Then the MDD comes and they say, well, we cannot classify it any further. And that at the end of it, we ended up classifying it as unclassifiable. That happens sometimes. So yeah, we do use it once in a while.
So I was thinking, like, in between the three, like UIP, NSIP, and airway-related fibrosis. So the best fit in this case is UIP.
Yeah, agreed.
You almost wonder if there should be a pathology MDD, right? Where you have like 3 pathologists look at it, right? And get the consensus pathology criteria, right? Instead of,
That's another can of worms, because there's no consensus between us either. No, I mean, that's not true. I mean, I think for classic cases, there is consensus. It's like anything else. The easier the case, the better the consensus. The more overlapping gray zone case, the less the consensus. I think but overlapping gray zone cases are more common in ILD than in tumor pathology, I think. That's why it becomes harder.
And I think it's also important to do it independently, right? A lot of times these consensus conferences, right? One person shows it and then it's like, oh, well, they think it's this, right? And
yes, and I think Matt, your point is especially valid for radiology. So once you know what the radiology is, like in this case, Irene told us the radiology is UIP. In that setting, it's much easier to call it UIP. I think pathologists are biased by that. if Irene had told us this patient is a 34-year-old with bilateral ground glass opacities, we would see exactly the same thing and we'd say, no, there's no way that this is UIP. No, there are too many macrophages. No, there's not enough scarring. So we get so biased by the radiology that we kind of manipulate the ground truth to suit the radiology. That's another complication in ILD, that the tumor, when we do tumors, we don't have to face that much.
So do you look at the histology before looking at any history?
Oh
or
yes,
radio?
absolutely.
Yeah.
Every time,
Yeah.
every time. I try to get my unbiased sense first, then look at the radiology and see, how much fighting will I have to do?
Yeah, residents know that when they're showing me the non-neoplastic lung, they will just give me the slides and sit quietly next to me, at least for a couple of minutes, without giving any history. And then they will say, like, whenever you want the history, we can tell you. Because it's always nice to go blinded fashion without any history and make your opinion. The direction, at least, whether you want to go UIP or is it smoking or is it NSIP or connective tissue or HP, and then ask the history, and then everybody, I think it's much easier. The job is much easier. Otherwise, like, you carry this baggage or whatever and in the mind, and you're trying, the mind is like such a crazy thing. It tries to take you in the direction even though you don't want to go, but it plays games with you all the time, especially my mind playing games with me all the time.
So in my case, it is like by default, I have to see the biopsy because I don't get the clinical findings and unless I ask repeatedly, ask them for it. So unbiased, like by default, I see all the cases unbiased.
That's
In my
good in a way,
case, it's
Sharda.
like
It's
that.
almost better to see
Yeah,
it that
yeah.
way, because you cannot be biased because you don't have that information.
Yeah.
It's I'm saying this jokingly, but I think in some ways it is better than
But
getting,
yeah, I agree.
like, for example, if you sit in a multidisciplinary discussion, they start with the history, right? So they start with all this history about this and that, and the patient was a nice man and his brother had this. You get so biased by the time you get to the pathology that, even if you see, you don't believe your eyes, after all that story that you have heard, it becomes so biasing.
I agree. Yeah.
Should we do the next case without history, look at the slide and then
Yeah,
go back, ask history from Irene?
yeah, let's do that.
So
Can you give us without the history the next case?
perfect. So you have to decide without any information who is going to see. I think Raghav is clarivident because this case no needs much history. Who wants this case? 1 second.
I think Sharda is the only one who hasn't. No, or has she done it already?
Sharada, take it.
Yeah, sure. So yeah, I could see this alveolated lung parenchyma, and yeah, there are bronchioles and there is fibrosis, and there is this pink eosinophilic material. Yeah, I could see this pink eosinophilic material which is filling the alveolar spaces, and can you go to the hyper? Yeah, this one. So yeah, it is granular.
Sharda, are you sure that there is fibrosis? Like now that you're looking at the high mag?
No. This is not fibrosis. This is the eosinophilic material which was
Right,
which is filling up the alveolar spaces. And so is it pulmonary alveolar proteinosis?
So Matt, can we do a pathology MDD before we hear the history now? Just like you suggested?
Yeah, so that would be top of mind, but I would do GMS just to make sure it's not.
Yeah.
GMS.
Now, what
Sharda,
if
would you
the-
do anything else? Would you do anything extra, Sharda? Any stains or
Yeah.
anything?
Yeah, PIS and GMS is both
PIS
things.
and GMS.
Because
Raghav, what were you saying?
what if the patient is immunocompromised?
PCP, yeah, PCP is another differential.
Yeah.
I have.
Exactly.
I would say, I agree with Sharda. I would say there is no way in hell that this is anything else except the PAP. It cannot be. This is not what PCP looks like, guys. I mean, you know that this is not what PCP looks like, right?
Yeah.
Yeah, it
There's
has
no
its-
frothy anything. You don't see those dots. There's no interstitial pneumonia. I mean, we can, there are those little blobs in the air spaces, the little cholesterol clefts. This is classic PAP no matter
Yeah.
what the PAS shows or the GMS. We all know that at some level.
But
That
would you
there's
not do
nothing
the
else.
GMS though?
But you can do it if you want to. Yes, of
Yeah,
course.
but would
Because,
you?
No,
even
no,
even
I
I
would.
do a GMS because I wanted to rule out any secondary, fungal infections in this.
Yeah. It would now be very interesting to hear if there's anything in the clinical that doesn't fit, and then what difference that makes to the pathology. I
Hmm.
don't think it makes any difference because this is PAP no matter what the clinical is. Okay,
Yes,
Rene.
it's a
Mean secondary PAP can occur in immunocompromised people. Only the primary ones is because of the GM-CSF antibody kind of stuff. And
Yeah,
then there is congenital one with this surfactant protein deficiencies or mutations. So the
yeah.
secondary ones can still have, and they can be focal PAP kind of pattern, but this one looks more diffuse and everywhere. And that eosinophilic globules are standing out in between that pink material. I generally call this as pink alveolar proteinosis than pulmonary alveolar proteinosis.
Raghav, have you seen the secondary
No, I've not.
PAP?
I've not.
That's all in the right. Unless you're a pediatric pathologist, you're never going to see that ever in your
Not.
life.
Yeah, I
And
have
the
seen
and,
PAP.
yeah, but
I
do you see pediatric path?
I used to
Right.
see in my previous workplace.
Yeah, so then you will see it. But if you see only adult path, you're never going to see those congenital things. And the only secondary PAP you're ever going to see is in silicosis cases. So you'll see silicoproteinosis in a massive silicosis background, but not in a biopsy like this, right? I mean, there's nothing to do with silica anywhere here. There's no silicotic nodules, no dust, no anything. So those theoretical things about what else this could be are really theoretical. I mean, I would say the chance that this is anything else is very close to zero other than PAP. Let's see.
I've
Maybe
seen
Irene will prove us wrong here.
I've seen an exudate like this in some explants that are not silicotic. In some areas, like this similar looking, but in very little area, focally, I mean. And so I don't know the meaning of.
So Irene, what is the chance that this is a fibrotic ILD where they have missed all the fibrosis and they just managed to hit that small area of PAP on a cryo biopsy?
I don't think there is
I
a
mean,
chance.
let's
And
be
the
realistic.
story fits
Yeah.
with the thing. It's a 50 years old man, light smoker who works in construction and who has chronic respiratory failure in study. And he's admitted to the hospital because of acute respiratory failure. And the CT sees crazy paving, and the BAL, the bronchoalveolar lavage, is white, and everything that goes with that. But they treat the patient, and the patient doesn't improve. And this is very weird for them, and they decide to do a biopsy to see if there is something else. So I did the GMS, and it was negative, and I had to diagnose alveolar proteinosis.
Did you do a PAS, Irene?
No, because I hate PAS, and I hate the people that order PAS in my biopsies, and I have to look at the PAS.
So no, wait, let me ask Sharda because she said PAS, right? So Sharda, my question for you is, let's say in a biopsy like this, your PAS is negative, or it's very light staining, so it's basically almost negative. Would you then say that this is not PAP?
This is PAP.
Like, so that is my point, like when the histology is so classic, what does the PAS really add to what you have? Would you believe it if it was negative? You wouldn't, right? Like in a solitary fibrous tumor, if your STAT6 was negative, you'd say, no, this is not solitary fibrous tumor, right? It cannot be. But in this setting, would I feel that the PS is not sufficiently sensitive that it would say that this is not PAP because of that's the reason that I don't do it. It's not like you shouldn't do it, but I feel like even if it was negative, it would not change my mind.
But,
Yeah, other than just adding color to the slide, I think the
Yes.
PAS would not add anything. But I agree with Pat that I would generally, and Irene, that I would generally do a GMS, even though I know that it's going to be negative. Otherwise, like the pulmonologist would call me and tell me, did you do a GMS to exclude PJP? And then again, I have to go back and do it. So I just do it on the go so that I don't have to go back on the case.
I've even had guys, a pulmonologist call and say, like, alveolar macrophages, like you get in every biopsy, foamy macrophages here and there. They called and said, can you do a BRAF mutation testing to exclude Erdheim-Chester? I said, no. They said, but do it, please, because I've heard that in Erdheim-Chester you get foamy macrophages. And I was like, please, somebody kill me now and put me out of this misery.
You got to
I
come work in
think-
Canada, Sanjay. You just say, "Oh, that testing's not indicated for this. The government doesn't fund it. Sorry." And,
I want to move to Canada. Please put me in Canada now.
They love to have something that is objective and that they can
Yes.
see, because they don't understand when we are talking about these things that we see and the fibroblastic foci and so when there is something like CD1A or BRAF or these things that are objective for them, if we can say CD1A is objective, they love to have these things.
Yes, but they can get into trouble with that, Irene, right? Like we have to explain to them, what if you get a BRAF positive in a case which has no morphologic findings of Erdheim-Chester? You'll get into more trouble. You'll go down a rabbit hole that there's going to be, it's going to create more trouble for the patient, not to mention the added cost of that unindicated testing for the patient. So I think I agree with you. I see it from their point of view, but I think we need to at least push back a little bit on things that are completely not indicated and tell them once in a while, look, please don't do this. It doesn't make sense in this case,
Agree.
like the Canadians.
In such cases, in PAP, it's like sometimes the clinician asks to do a PAS.
Yeah. No, I agree, Shada. I mean, I know why people do it. I'm just trying to explain why I don't do it. But yeah, I get the point. And clinicians will sometimes write on the paperwork, they'll say, suspected PAP, please do PAS.
Yes, they do this.
I think
just like they say, suspected vaping, please do oil redo, right? Suspected
I think the only times that they have asked PAS to me were when they were not, when the clinical picture was not that clear for them. So that's when they want. If you say alveolar proteinosis in this case, they are okay. But if I remember one time that we have it in a transplant patient or something like that. They are not the story doesn't fit, so they want something else.
Sanjay, in your reports, you maybe should start indicating tests the clinicians should do that are really obscure, like suggest whisper pectriloquy or something like that to rule out consolidation of the right lower lobe.
I should say, in ILD cases, suggest taking a full clinical history with HP questionnaire as suggested by the ATS-ERF. Yeah, I mean, it's ridiculous, it's ridiculous that one specialty can force another one to do an unindicated test, but that's just how it is. That's our life. We have to deal with it.
Sorry?
It has to be mine. Yeah, mine. No history, please. No history.
So no history for you. Here, the liver in this case, not non-cirrhotic liver.
My God, once in a while when I see another non-lung organ, I'm like, oh my God, I really miss non-pulmonary pathology.
So even
no cirrhosis in the liver.
All right, guys, we've got alveolated lung, beautiful Irene cryobiopsy, big pieces. And she's trying to show me something, but
no, just wanted to go farther. One. Another one.
So far, I don't see a lot. There's a little, okay, so there's a little bit of inflammation in the interstitium. Like here, there's a multinucleated giant cell next to that one. There's a, yeah, thank you for showing me at Hi Maggie. I would have missed that. There is a carcinoid tumorlet, I think there. Yeah, there's a carcinoid tumorlet. I saw a little bit of elastotic scarring in the background of that tumorlet and here and there. What else? Show me high migraine. Yeah, this is definitely a tumorlet. What else? There's a bronchiole here. There's some normal lung to the right. I'm not very impressed by any of this.
No, but
Chronic inflammation, minimal. Some elastotic scarring next to on the left-hand side. Very little. Not impressed. Same. Elastotic scarring, minimal chronic inflammation, patchy.
I think this far we can say it's not NSIP
Yes.
because we have normal lung, and it's not UIP because we haven't seen
Yes. Agreed.
fibroelastic foci or scarring. So what would you do with this biopsy?
Nothing. Descriptive.
But
Yes.
if you go to the history and they say that it's a 80-year-old man, smoker, and it's a farm,
It's a
does
farm.
it change your?
No, it does not change my diagnosis at all.
But there's one
No,
giant
you-
cell, Sanjay.
There's one giant cell.
And there are
Yeah.
there is some inflammation.
Yeah. So if they say we really want to make this HP, I'll be like, fine. The changes are extremely minimal and not really very convincing. But if you know, if it's classic HP by clinical findings, that's great.
No, but here, for example, I see some inflammation in this
Yes.
interstitium, and I found the giant cell.
Yeah.
So some pneumonitis, and it's a bit centrilobular.
Agreed. Yeah, I think that's fine.
So this with the with the history, it could be
HP?
HP.
Sure.
Without the history,
It's
I
nothing. Without the HP, it's nothing.
I'll diagnose that. I mean, I'll say patchy light pneumonitis with one giant cell, something. I don't know. I don't remember the name I said to that, but it's something that I would diagnose it. I would say it, and if it goes with the history, they have an HP.
Yes.
You won't
Agreed.
say look for HP with that. You won't say.
What's that? Look for HP?
Look for HP, and because when I see light pneumonitis and a giant cell, I put a comment like this could be HP just if you think so, or I don't know, I say it in Spanish. This could be HP in the appropriate context.
Yes, yes. No, I think that's fair. I probably wouldn't because I hold out for a little bit more lymphocytosis, a few more giant cells. But if you suggest that, I think that's fair. It's not unreasonable. For the same reasons, I mean, you could also suggest CTD-ILD. You could suggest drug. I don't think that's unreasonable either. But yeah, it's okay to suggest. I don't think it's very classic. That's how I would put it. It's not a classic HP. Guys, Sharda, Matt, Raghav.
I will go for a deeper section before I.
I don't have it here for you, sorry, but I have many sections in this in this case, and this is the good section, the one that had the giant cell, and I have not more things of HP.
In my experience, in such cases, the deeper sections did reveal a granuloma with few multinucleated giant cells.
Yeah, I agree with Sanjay. I think I'd be descriptive. I think I'd just highlight some pertinent negatives. But this could be HP, but I would once again highlight that it's really kind of mild changes, and make sure that correlates with everything, right? Because I would just worry that it's a poorly sampled biopsy too, right?
So, Irene, what was the history that made this HP in this case? What was the compelling thing in the history
Also, the city, no, well, he was a farmer,
Oh, farmer. Okay.
and the city was classic. I missed to say the city. The city was emphysema with ground glass and air trapping. So
And a what?
Air trapping.
Air trapping.
Air trapping.
Let's say the patient was not a farmer, but the CT showed the same finding. Would it still be HP?
I think so. In
Would
my
still be-
hospital,
Yeah.
in my hospital, I think so.
So it's really the CT that's driving it, not the farmer, right? What if there was ground glass but no air trapping? Would it still be HP?
It's Saraya.
Good question.
See,
Good
what I'm trying to
question.
get at is that the clinical features that make it HP are also very fuzzy. They're
Yeah.
fuzzy
Yeah.
features which can change with one parakeet versus three parakeet, farmer versus live close to a farm, air trapping versus mosaic versus something else. It's very fuzzy and it's very open to negotiation and discussion. There's nothing definitive about it, like PAP, SRIF, something that you can put your foot down on. HP is very negotiable with a biopsy like this.
Yeah, I agree. Definitive features are not present. So I would, like Matt was saying, exclude pertinent negatives. Again, depends how much we can exclude, considering the area of the biopsy. But otherwise, the findings are very subtle and minimal, and I'll be descriptive as well. And open for negotiation.
Yeah, I mean, it could be the other way around too. You could say this is a 43-year-old woman who
Yeah.
has been breeding pigeons since she was 15 years old. She gets
Right.
symptomatic every time she comes in the home and comes out. If they told me that, I'd say, oh yeah, great, this is HP, fine. Of course it is in that setting, but it very much is setting dependent here. It's not dependent on the pathology.
A bit of bronchiolitis also.
Yes.
No, it's true. I think, but I'm afraid that HP is now just like UIP. That is something that it's so city driven
Yes.
that I think sometimes it's not is suggested not to do the biopsy in some settings. I mean, if you have the CT and these antigens or antibodies done, they can not to do a biopsy. So it's something that so CT driven nowadays.
Yes, agreed. That's because the radiologists are, no, I'm just kidding, but part of the reason is the radiologists are always united. They say, yes, radiology can do this and ground glass, it's very safe for the patient. Biopsy is so dangerous. And pathologists are always fighting among themselves. They have no inter-observer reproducibility. So they make us look so bad that the overall story is always that radiology is always better and pathologists are always fighting about whether it's UIP or not and this and that. That's the overall story for the clinicians. It's much easier to do a CT, much safer for the patient. So why not just do just a CT and forget about the biopsy? What about your tumorlet, Irene? What did you do with that? Ignored?
Let's say
Ignored your
tumor.
tumor.
I think the bronchoscopies have a special appealing for tumorlets or meningothelial nodules, and then when you look at an explant, this is so minimal
Yes.
that you think, what were the chances that they got that in the bronchoscopy? I don't know if the probe goes to plumpy things or what, but I see many meningothelial nodules, many tumorlets.
Yes. What would you do if the CT was classic for dip neck?
I mean, I did chromographing in this case to see if it had neuroendocrine hyperplasia in addition to the tumorlet, but it had not. Was only the tumorlet. I couldn't see more chromographing positive cells in the bronchial. We have this problem with deep neck, no? Now that there is a pathologic definition that it's like a pathology definition and then the syndrome definition. So
big problem. And nobody agrees on what dyspneic is or how it should be defined or whether it's pathologic or
confusing.
clinical. Big problem.
It's confusing, but in this case, as there was no hyperplasia, I had no problem.
You had your
So-
giant cell, so you're done. The giant cell wins over the tumorlet.
It's a great case.
Yeah,
That's,
the mighty giant cell wins over the groups of carcinoid tumorlet cells.
They had a little battle, the giant cell versus the tumorlet. And once the CT came up, the tumorlet fell down, defeated by the
To be honest, I think I've seen this more times than that. That's why I don't say this is HP. Never, even when it's classic. I don't say it in the line because I feel I've seen pneumonitis a bit. What is the definition? Because you are much more strict, but as I'm so light to say that, yeah, what is to have some pneumonitis and to have a giant cell is nothing that's I think we can see it in many settings, but we also have seen it in proven HP. So I don't know.
Yes, and that's actually one of the arguments I make is pathologists, like you are saying, Irene, many pathologists don't even call it HP on the line diagnosis, even if it is classic HP, right? They will describe and not call it. So I say, even if with the full-blown classic HP features, if you don't call it HP, then why does one granuloma in a UIP case make it HP? It makes no sense. It makes no sense to me that there are different criteria for different things. But anyway, that's a discussion for different time.
It's a great
Thank
thing.
you. Lovely case. Lovely
I think
case.
Raghav has to go to Frozen, so thanks
Okay,
everyone.
I think we're
Yeah.
done, right?
Yeah, we're done, yeah. Thank you everyone, and I'll get
Thank
this
you.
all edited and put together.
Great discussion, guys. Thank you so much.
Thank you very much.
Enjoy.
Thanks for joining. Great
Bye.
cases,
Thank
Ernie.
you.